Hello everyone, I am Dr. Giriraj Sharma. I am consultant neonatologist at Vatsalya Shishu Hospital, Ajmer. And today our topic of discussion is high frequency oscillation, HFO, mode of ventilation. So in next 15 minutes, we will be discussing what is HFO and how it is different from conventional ventilation, what are the indications of the HFO in neonatology, what are the different parameters or settings that we have to set in HFO, how to initiate HFO ventilation, how to adjust the settings according to the patient and according to improvement, how to wean and when to extubate, how to extubate on from HFO, and what are the different types of complications of HFO ventilation. So first coming to what is HFO. So HFO, high frequency oscillation. HFO is a type of ventilation which delivers very small tidal volume at very higher rates. Means tidal volume is very less, around 1.5 ml per kg to 2 ml per kg. It is less than the dead space. Okay, so tidal volume is very less and rates are very high. Rates are 5 hertz to 15 hertz. Means 1 hertz is 60. So between 300 to 3000 breaths per minute. Okay, so it delivers very high rates, 300 to 3000 breaths per minute. Now coming to how HFO is different from conventional ventilation. So as we discussed that here tidal volume is very less and rates are very high. Tidal volume is less than even dead space, rates are very high, 300 to 3000 per minute. And in conventional ventilation rates we are giving around 40 to 60 per minute as physiological rates of newborn baby. So this is the difference. Next, in HFO, inspiration and expiration both are active process. Okay, inspiration and expiration both are active process. HFO is giving inspiration and then expiration also is active process. Okay, but in conventional ventilation, inspiration is active, but expiration is the passive process. This is the difference. Next, HFO delivers continuous distending pressure. Okay, HFO what is doing? Delivers continuous distending pressure and recruits the lungs. Okay, after recruiting lungs, HFO will wobble, lungs will wobble like this. But in conventional ventilation, inflation, deflation, this is the process. But in HFO, continuous distending pressures maintains there and then wobbles there. This is the difference. Then in HFO, oxygenation and ventilation is decoupled. Okay, means we can control separately oxygenation and ventilation separately. If you want to increase oxygenation, we can increase only oxygenation. If you want to increase ventilation, we can increase directly on ventilation. But in conventional ventilation, if you want to increase oxygenation, then ventilation also will increase. If you want to increase ventilation, then oxygenation also will increase. So both are related, associated, but here both are separate. Okay. Then in HFO, if you increase the rates or frequency, then CO2 also will increase. But in conventional ventilation, if you increase the rate, CO2 will decrease. Why it happens, that we will discuss later. Now, what are the indications of HFO in an ICU? So, HFO we use generally rescue mode, or we can use as a elective mode also. In rescue mode, we use when on conventional ventilation, if pressure requirement are very high, means pressure requirement is like more than 25 or more than 28, FiO2 requirement is more than 60%. So pressure and FiO2 requirement is very high, then we can use rescue mode of ventilation HFO. Or failure of conventional ventilation, means even on higher settings of conventional ventilation, if PO2 is less than 60 or PCO2 is more than 60, okay, means conventional ventilation is failing. In that condition, we can shift baby on HFO. That is the rescue mode. Then elective or primary we can use in some diseases. Many units use like in MAS, PPHN, congenital diaphragmatic hernia, pulmonary hemorrhage, pulmonary interstitial emphysema, or even RDS also some units use HFO as a primary mode. Next point is what are the parameters or settings we have to set on HFO. So 5 parameters are there on HFO. First is mean airway pressure, FiO2, delta P, or we can call amplitude or power. Delta P, amplitude or power, frequency or rate, and IE ratio. Okay. So Here there is no PIP or PEEP, there are no two pressure, only one pressure is there, mean airway pressure, means average pressure throughout the respiratory cycle, that is called mean airway pressure. So mean airway pressure and FiO2 decides oxygenation. Here in HFO, to separate oxygenation and ventilation are separate. So mean airway pressure and FiO2 decides oxygenation, and delta P and frequency decides ventilation, means CO2 washout. So both are decoupled. We can increase oxygenation separately or we can increase ventilation separately by these settings. Okay. So first coming to mean airway pressure. What is mean airway pressure? So mean airway pressure we have to set on HFO to recruit the lungs. So this will provide continuous distending pressure. Mean airway pressure will provide continuous distending pressure to the lungs, and that will recruit the lungs like CPAP. Okay. After recruiting the lungs, delta P will provide wobbling. So what is delta P? Delta P is the range of the motion of the piston. So piston will move to and fro like this. So how much is moving range of the motion is the delta P. It's like delta P small, this much piston is moving. If you increase the delta P, this much it will move. So that will provide the wobbling or wiggle. Okay, that will decide the CO2 washout. Frequency, so mean airway pressure we can set like 8 to sometimes 15, 16, that depends on the lung condition, up to 20 also we can go. So we can increase slowly. Delta P we set generally twice of MAP. So delta P twice of MAP generally we set, and then we'll decide according to wiggle and CO2, that we'll discuss later. FiO2 will decide according to SpO2, PaO2. Okay. Next is frequency. So frequency we keep for term babies around 8 to 10, for preterm babies is 10 to 12. Okay. So this generally we fix for term and preterm babies, and then generally we don't change. Means larger the baby, smaller the frequency, severe the disease, smaller the frequency. Okay. Term baby is 8 to 10, preterm 10 to 12. IE ratio will generally fix it 1:2. If problem in oxygenation is there, then sometimes we can keep 1:1. Otherwise, 1:2 will keep. IE ratio generally we don't change. Frequency also we don't change. We'll change only, we'll adjust mean airway pressure, delta P and FiO2. So mean airway pressure we can keep 8 to like up to 20 also we can go. Delta P just twice, 16 to 30 or 40 sometimes we can go. FiO2 depending on 21 to 100% depending on the requirement. Then how to assess the adequacy of that setting? Mean airway pressure is adequate or not, that how to assess? So mean airway pressure we have to assess depending on the SpO2 of the baby, PaO2 and ABG, and chest X-ray expansion. So SpO2 we want 90 to 94%, PaO2 we want 50 to 70 or 80. Chest X-ray we want 8 to 9 space expansion. In conventional ventilation we want 6 to 8 space expansion. Here in HFO we want 8 to 9 space size expansion of posterior ribs. Okay, that means lungs are adequately recruited. Means mean airway pressure is normal. If lungs are still 6 space or 7 space, then we can increase the mean airway pressure. If SpO2 is not maintaining, we can increase the mean airway pressure or later FiO2. Then FiO2 according to SpO2 we can decide 90 to 94%. Then delta P. How to assess the adequacy of delta P? That depends on, first is wiggle or wobbling of the chest or abdomen. Second is the PCO2 level. So wiggle we want up to the lower abdomen, below the umbilicus. Okay, that is the normal wiggle. If wiggle is up to the legs, then means wiggle is more, so delta P we can decrease. If wiggle is up to the chest only, it not going up to the abdomen also, means wiggle is less, we can increase the delta P. So wiggle we want up to the lower abdomen, that is the adequate wiggle. According to we will decide delta P. Second is the PCO2 level. If PCO2 level is higher, then we can increase the delta P, that will wash out the CO2. If PCO2 level is lower, then we can come down on the delta P. Okay, so according to PCO2 and Weigel will decide delta P levels. Next is frequency. First we have started maybe on term baby this and preterm baby this. After that we'll generally don't touch. If delta P is very low, still CO2 is low, then we can increase the frequency. Otherwise we don't change the frequency. Here if you increase the frequency, CO2 level will increase. This is opposite to the conventional venting. In conventional venting, if you increase the rate, CO2 will decrease. But here, if you increase the frequency, CO2 also will increase. If we decrease the frequency, CO2 also will decrease. Means CO2 washout will happen. Why it is happening? Meaning that increasing frequency, increasing the CO2. So if you increase the frequency, then piston will get less time to move. Okay, means volume displacement will be less. So here if you increase the frequency, piston will move like this. So it will get less time to move and volume displacement will be less. So tidal volume will decrease. If you increase the frequency, tidal volume will decrease and CO2 will increase, because tidal volume only will wash out the CO2. So if you are increasing the frequency, piston will move very fast, will get less time to move, more range of movement. Tidal volume will decrease, volume displacement will decrease. Because of that, CO2 will increase. If we decrease the frequency, means piston will get more time. Piston will get more time to move. That will displace more volume, more tidal volume. That will wash out the CO2. So CO2 will decrease. This is the concept behind the frequency and CO2. Okay. Next is IE ratio. IE ratio will keep 1:2. That will don't change. If oxygenation is the problem, then we can keep 1:1. Otherwise, we don't change this. So these are the parameters. Now coming to how to initiate the HFO. How to start the, what are the settings we should keep at initiation of HFO. Okay. So generally we shift baby from conventional to HFO rescue mode. So settings map, how to decide. So first map we will keep 2 centimeter of H2O above the conventional map. So if baby was on conventional ventilation, let's see if baby was on map of 10 map on conventional ventilation, then here on HFO we'll keep slightly higher map, 2 centimeters. So here we'll keep 12 centimeter of H2O mean airway pressure. So 12 map we'll keep here, slightly higher generally we keep. Okay. Second, delta P. Delta P initially generally will keep twice the map. So if 12 was there, here delta P will keep around 24 or 25. Starting delta P will keep, and later on will adjust according to Weigel and CO2 level. Okay. Frequency I told you, for preterm babies 8 to 10, preterm babies 10 to 12. For starting will keep, and generally we don't change it. FiO2 depending on SpO2 and requirement, 60 or 70 requirement will keep. IE ratio 1:2 will keep. These are the initial settings for HFO. Next, adjustment of settings. After initiation of HFO, we have to adjust settings according to the baby. So after starting HFO, after 30 to 60 minutes, we have to do ABG and chest X-ray. Okay, ABG and chest X-ray we have to do to see the level of expansion of the chest and CO2 and PO2 level. So mean airway pressure, how to adjust? If SpO2 is going more than 95%, PO2 is going more than 80, okay, or chest X-ray expansion is more than 9 or 10 space expansion, means expansion is more, PO2 and SpO2 is more, then we can come down on mean airway pressure. Means mean airway pressure decides oxygenation and expansion. Expansion is going more, oxygenation is more in ABG and SpO2, means we can decrease the mean airway pressure slowly by 1 to 2 centimeter H2O each time. Or second condition, if baby is not maintaining oxygenation, means saturation 87%, PO2 still is 35, or expansion also is not good, baby's chest expansion is around 6 space only expansion, lungs are not recruited, that's why oxygenation is not happening. Then we have to increase the PO, means MAP. We have to increase the MAP, that will recruit the lungs, that will increase the oxygenation. So to increase oxygenation, we have to recruit the lungs. How to recruit? By increasing the mean airway pressure. So we know how to increase mean airway pressure by 1 to 2 centimeter S2O each time. Every 5 minutes we can increase, and slowly we increase, and we'll see that after how much MAP. Let's say we started by 10, increase to 12, then 14, still not increasing, then 16. After 16 MAP, oxygenation improved, SpO2 improved, means that is the opening pressure. Okay, after opening, this is the opening pressure. After this will increase more, like 17, 18, and one pressure will come. After that, oxygenation will start decreasing, means their hyperinflation is there. After will come down again, and just will keep just above the closing pressure, where oxygen starts decreasing, just above that will keep MAP. So how to decide MAP? So first we have to increase the MAP, increasing. After that we are decreasing, where closing pressure is coming. After that is oxygen starts decreasing. Above that we just will keep MAP. Here will keep MAP. So this is the how to decide the mean airway pressure. So how to adjust delta P? After starting HFO, after 60 minutes we did chest X-ray and ABG. In that PCO2 we have seen PCO2 is, let's see, is high, still high, is PCO2 is 70. Okay, so PCO2 is still 70, so we have to increase the delta P to wash out the CO2. So we'll increase the delta P. We can increase 2 to 3 or up to 5 also we can increase. After that 2 hours again we'll do PCO2. If let's see PCO2 sometimes is going down, is 30 only, then we can decrease the delta P. So delta P will adjust on the basis of the PCO2 levels, and second I told you on the basis of the Wiegels. Okay, so this is the for delta P. Next is frequency. So frequency we started like, let's say term babies we started by 9, and generally we don't change, we adjust only mean airway pressure, delta P only, and FiO2. So frequency generally keep fixed only. But if let's say CO2 is, PCO2 is very low, like PCO2 is 25, is very low, and delta P already we have decreased up minimal, like if we delta P already will decrease to 15 to 20, delta P is very low, Wiegel is minimal only, but still PCO2 is very low. In that condition only we can increase the frequency, we can increase to 10 to increase the CO2 level, because by increasing frequency here CO2 will increase. In that condition only we can adjust the frequency, otherwise generally we don't touch the frequency. FiO2, I told you FiO2 depending on will increase or decrease. If baby is improving, oxygen is improving, will decrease by 5%, we can decrease. IE ratio we keep 1:2. If oxygenation baby is not maintaining, still after increasing mean airway pressure, still baby is oxygen not maintaining, we can keep it 1:1. That will increase the tidal volume, and that will increase the oxygenation also. So these are the how to adjust the setting. Now coming to when to start weaning and how to wean on HFO. So when baby is improving, lung compliance improved, oxygenation improved, ventilation improved, then we'll start weaning. So first we'll start weaning FiO2. First we'll start FiO2 means previously was 90%, then we'll decrease slowly 85, 80, like this will start decreasing. When it comes to the 60%, FiO2 comes to 60%, then we'll start decreasing the mean airway pressure. If lungs are not hyperinflated, if lungs are hyperinflated, we can decrease the MAP before the frequency also. But lungs inflation are like 8 to 9 space expansion, not hyperinflated. Then first we'll decrease the FiO2 up to the 60%, then we'll start decreasing the mean airway pressure by 1 to 2 cent. Previously was 18, then we'll decrease 17, then slowly we'll decrease 16 if baby is maintaining oxygenation, and FiO2 and MAP will start decreasing. According to the mean airway pressure will decrease the delta P also, simultaneously will decrease the delta P. If baby's ventilation is good, CO2 levels are good, so and vehicle is good, so both will decrease simultaneously. This frequency and I ratio will keep constant. Now, when to extubate from HFO and how to extubate. So, if by weaning MAP has come to 8 and FiO2 has come down to up to the 30%. After MAP of 8 and FiO2 of 30%, we can extubate the baby directly to the CPAP, or most of the units practice, they will shift first on conventional ventilation and then they will extubate on CPAP. Both we can do. Directly we can extubate, or first we can shift to conventional ventilation and then we can extubate. Now coming to what are the complications of high frequency ventilation in newborns. So first is the hypocarbia. Means sometimes if we don't do ABG frequently, then what will happen? HFO will wash out CO2 very rapidly and CO2 will come down rapidly, and that will cause hypocarbia. Hypocarbia is a risk of periventricular leukomalacia. If prolonged hypocarbia is there, that will cause the PVL. Okay. Next, HFO will recruit the lungs. If sometimes hyperinflated, then that will increase the thoracic pressures, that will decrease the venous return, that can cause shock also. Okay, hypovolemic shock that can cause, because of decrease of venous return, that can cause hypovolemic shock. Third, it can increase the central venous pressure, that can cause IVH also. Some studies have shown, but after that newer studies does not support this, but some studies have shown increase of IVH. Then because of hyperinflation, sometimes it can cause pneumothorax also. Okay, so we have to do frequent chest X-ray and frequent ABG monitoring to prevent these complications. Okay. Next is it can cause necrotizing tracheobronchitis also. So these are the common complications of HFO ventilation. Now coming to what are the benefits of the HFO ventilation in newborns. So first here we can see that here tidal volume is very low. Tidal volume is very low. So it reduces risk of the volutrauma, because here we are giving very low tidal volume on higher rates. So risk of the volutrauma is less in HFO. Second, we can see mean airway pressure in HFO is less than the PIP. Okay, PIP we give sometimes 20, here mean we are giving 10, 12 or 13 something, but it is still less than the PIP. So it reduces the risk of the barotrauma also. So reduces risk of volutrauma, barotrauma, and reduces the risk of atelectotrauma also, because here HFO is providing continuous distending process. But in conventional ventilation, what's happening? Inflation, deflation, that causes atelectotrauma. So in conventional ventilation, atelectotrauma happens. In this, it doesn't happen. So it reduces the risk of these traumas. But what evidence says? Evidence does not support that. Evidence says there is no reduction in mortality. If you use elective HFO in different diseases, it does not reduce the mortality. Some studies shows that there is a small reduction in the BPD, but still there is no major change. So it does not reduce the mortality and BPD in preterm babies. So these are about the benefits of the HFO ventilation.